on the side of the screen, there are a lot for you. Pick any if you want to get everything. Each point matters and it counts. When we're done with the observations, we are going to go into our psychological care. We need to ensure this patient is well equipped emotionally as well. Okay, so I'm also going to remove one point on psychological care. There's a point that we like saying, I will introduce the patient to another client in the ward who has a similar problem. Is emergency preoperative care. The point at the moment we are introducing the patient to another client, the patient will be dead. Okay, we need to intervene right away. We do not have chance and time to start the introduction. So we are going to go into the main psychological care where we are going to say, I will explain the whole condition process to the client and make them understand in order to allay anxiety. The other point that we are going to have on psychological care is that the other point we are going to have is that I will allow the patient to ask as many questions as they can or as possible, and I'm going to answer them truthfully and honestly. Why are we doing that? We are trying to allay what? Anxiety. Okay, I have a lot more points on anxiety, and you can also identify your own points that you want, but make sure you identify points that are valid. Okay. Then we are going to go into investigations. When you're done with the psychological care, we are going to go to investigations. By the way, psychological care and observations, you can use them. They can come interchangeably. It's fine. Okay. Yes. But afterwards, we are going to go into investigations. So investigations, number one that we are going to have, the investigations, it is not UNS who is doing them. That's why on investigations, we are not going to say, I will do this. No. If you are doing a full blood count, or if a full blood count has to be done, you are just going to say full blood count. And why are we doing it? We are doing it to rule out infection in this case. It is the lab technicians who are doing the investigations, so that's why we are not saying I will. The other investigation that we can do is hemoglobin count, because we want to do we want to rule out hemophilia. We can also do platelet count because we want to rule out anemia. We can also do other investigations, but when you put in the investigations that I've given you, or the ones that you can come up with, also find two or one investigation that is pointing out to the condition, the real condition in the STEM question. For instance, you can say a CT scan. A CT scan is going to confirm the condition and the diagnosis. X-ray, you can say X-ray. It can also confirm the diagnosis and the condition in particular. Okay, you can cut. Okay, so after the investigations are done, we are going to go direct into consent signing. After having done all this, the next thing is consent signing. So even if you manage or you achieve to do all those things and the patient doesn't sign the consent form, do not proceed with the rest, and surgery is not going to take place because you are not protected as a medical practitioner. Even the client themselves, they are not protected. So meaning anything that is going to happen, all fingers are going to point back to you. So under consent signing, we are going to say, after having explained the whole process to the patient and making sure that the patient has understood and signed a consent form. A consent form, which is a legal document that is protecting the rights of a patient and the rights of a medical practitioner. I will proceed into preparing the client for surgery, which are the physical preparations. And on the physical preparations, the first one that we are going to have is gastric preparations. Okay, and why are we doing gastric preparations? We want to eliminate, we want to remove or reduce the gastric content so that it doesn't interfere with surgery. A patient can be on a surgery can be taking place, and the patient can start aspirating. Those gastric contents can even go into the lungs and the patient aspirates and dies whilst during the procedure. That's why we are always putting the patient on new pe oro. So you are going to say, I will put the patient on new pe oro. Okay. Other than putting the patient on new pe oro, we are also inserting an NGT, which is a nasogastric tube, the tube that is entering from the nose and it goes all the way into the stomach. Okay, that is also helping and reducing the risk of this patient aspirating in case of gastric secretions. Okay, this one is also helping us to get rid of the gastric content in case we need to do a gastric lavage. Okay, then the next point we are going to have is bowel preparation. We have to ensure the patient eliminates their bowel before surgery. Okay, if the patient is unable to eliminate the bowel before surgery, we are going to perform an enema. Okay, and when performing enema, it is going to be strictly under instruction and supervision of the higher superiors. Okay, why are we doing bowel preparation? We don't want any accidents to happen or any perforation or anything in the bowel to obstruct surgery or to interfere with surgery. The same way we are also going to do bladder preparation. We are going to ensure we eliminate any presence of urine in the patient's bladder. We don't want it to interfere with surgery. We can have complications such as perforation to the bladder during surgery, which is a complication, and we do not want that. We also do not want a bladder which has bulged full of urine to interfere with surgery. We can have complications such as perforation to the bladder during surgery, which is a complication, and we do not want that. We also do not want a bladder which has bulged full of urine to interfere with surgery, to obstruct surgery. Okay, that's why we're also doing the bladder preparations. Then we are also going to do the skin preparations. Okay, on the skin, we all know to say we have what we call the normal flora, which is just the bacteria that is there doing a lot of its own functions, one of them being the immune system boosting, etc., etc. But we do not want it to be there on the site of incision. Okay, because when surgery is being performed, that bacteria can start causing infection now on the site of incision after surgery. So we are going to get rid of that. So that's why, and if there's any presence of hair, we are going to make sure we trim the hair. We are not going to cut the hair. We are going to trim it. We are not shaving the patient, but we are trimming the patient. Why are we trimming the patient? When trimming the patient, we are not being in contact with the skin, because if we're in contact with the skin, there are high chances we can end up injuring the patient, and that normal flora can start entering the wounds. And what is going to happen? Infection we are going to give the patient. Then when we are done with that, we are going to go into pre-medication. So the pre-medications is just the medications that we are giving to the client before they go for surgery. Number one, we are going to give is magnesium trisilicate, commonly known as MMT. Why are we giving magnesium trisilicate? We want to neutralize the gastric content. In case of there's any gastric secretions, we have to neutralize it. Remember, this patient is on new pe oro. They are not eating anything. So if at all we have any hydrochloric acid being secreted in the stomach, it is going to start causing ulcerations there. Okay, so we want something to neutralize. That's why we are giving what? Magnesium trisilicate. Then we are also going to give um, promethazine. Okay, Promise can be given, atropine can be given for atropine. We're just preventing more secretions. When we are done with the pre-medications that we are going to give, now we are going to go into the removal of jewelry. Okay, why are we removing all the jewelry from the patient before they go for surgery? One, a patient who was on the cardiac bed, they can end up being electrocuted because of the presence of what? Their jewels, okay, necklaces, the ring, any other jewels they might be having. And in case there is need for MRI to be done, which is an investigation, those jewels can also end up interfering with the procedure. That's why we do not need them present on the patient. Okay. Then the other point we are going to go into is gowning. We are going to strip the patient of their clothing and we are going to give them a special gown, a special sterile gown, okay? That is infection free because the theater area, that room is an infection free zone. We also don't want infection from their clothing to be going onto their skin, into the openings that the surgeons are doing. So we are removing all their clothing and give them a special gown. Okay. Then we are going to go into patient identification. So this is a very important point and also cardinal. For patient identification, we are going to place name tags on the patient. It can be the shoulder, it can be the forehead, or both the shoulder and the forehead. Why are we doing this? It is common, sometimes a wrong procedure can be done on the wrong patient, or a wrong procedure can be done on the right patient. Anything can happen. So we have to ensure on the tags we indicate the name of the patient, the age of the patient, the gender of the patient, the ward in which that patient is coming from, and the procedure that is being done on that patient. It is very much important and very cardinal. After that, we are going to go into patient transfer. Okay, now you are going to transfer, you are going to arrange everything for the patient and hand over to the scrub nurse. Okay, so we are going to get the drug chart for the patient, the chart where we've been indicating the vital signs, and the patient's file that has been opened by the doctor. Okay, and we are going to go with them. We put on the patient's bed and take them to theater. As we do that, we should also ensure the patient's belongings, the personal belongings of the patient, are safe and secured and stored in good storage to avoid them going missing. Remember, this is our client and we have to treat our client with caution and very well. Okay, then the other thing we are going to do on patient transfer is handover. Okay, we have to give handover to. Okay, so after having made the handover to the scrub nurse, explaining everything that you've done on a patient, everything you haven't done yet, the scrub nurse is going to pick it up and they are going to do the rest inside and they're going to remain outside. The next step is for you to go back to the ward and prepare the post-operative bed in preparation for the patient's arrival. When you're done preparing the post-operative bed, now do your IEC, do your communication to the patient.